Hello, and welcome to my NUR30005 High Acuity Nursing Makeup Presentation. Case presentation. We have Mary, who's a 48-year-old Aboriginal woman. She has been transferred to the ward from A&E for medical diagnosis and management. She weighs 78 kilos, which is in the high BMI range. She is a smoker. She was sent to hospital by her GP following complaints of lethargy, excessive urination, and thirst. She has lost 4 kilos in the past couple of weeks. She currently has a UTI, is confused at times, and her past history includes hypertension. She appears diaphoretic, dehydrated, and she has breath smelling of ketones. So, action plan so far is nil by mouth, administer fluids, IV, install a fluid balance chart and bowel chart. Administer medications as charted for UTI and DKA, monitor vitals, GCS, BGLs hourly until ketones are gone and the pH is balanced. Check for potassium levels and administer potassium prior to insulin therapy to aid in the insulin uptake, because it goes into the cells at the same time, and if she keeps feeding it out basically, she will cause hyperkalemia, which causes cardiac problems. So electrolyte replacement, because it's also magnesium as well and other things. Check for phosphate, and 4-hourly urinalysis to monitor the pH, ketones and glucose levels. As I said, monitoring the GCS score and alert the doctor if decreasing. Assess for signs of peripheral vascular disease, kidney, liver function, and cholesterol tests. Frequent repositioning and skin assessments, checking for pressure injuries and edemas. Involve the endocrinologist, dietitian, diabetes educator, podiatrist, Aboriginal health worker from Mary's home and family. Evaluate the patient's knowledge about diabetes and the management. Evaluate their readiness for education as well, because she's come in with confusion. So talking to her about insulin resistance is probably not going to go down really well right now. But education we need to look for and the right way to give it when we can, about keeping physically fit and active, what happens when you have an infection and your glucose going higher because your insulin's not working as well because you're in a state of stress. Also happens with UTIs and pneumonia and other things. We need to talk to her about her diet as well. So low fat, low sugar, low carb, and talking about the medications that she's currently using, when to have them, when to check her blood sugar as well. Talking to her about the similarities of the signs of UTIs and hyperglycemia, and talking to her about the side effects and importance of regular BGL monitoring and blood tests 3 monthly, and health checks with your GP, regular skin checks and podiatrist to cut toenails. Basically, her blood is acidic because of the hypoglycemia, so as in diabetic ketoacidosis because of the ketones, and it's becoming toxic to her organs. So the initial assessment, doctors A, B, C, D, so danger to self, the environment or the staff, because often they can become aggressive or agitated. Response, so assessing GCS and level of consciousness. Send for help. You'll need a lot of multitasking to be done through the pathway and getting things ready, so everything's done in a timely manner. Airways, the decreased level of consciousness can affect or compromise the airways, so making sure that that's always open. Breathing, so often you'll find Cushmal respirations because they're trying to blow off the excess CO2 through their breathing, to decrease the acidity. Circulation, so we need to look at the antibiotics straight away. We need to give her volume because she's dehydrated. We need to look at the skin turgor, of course, and yeah. So going through your primary assessment of diabetes, Neurologically, you have altered level of consciousness, confusion, lethargy, as I said, irritability, and possible coma. Stroke-like symptoms, so bilateral or unbilateral weakness and paralysis and numbness, so paresthesia and fatigue. Respiratory, so deep and rapid respirations called Cushmal respirations. Cardiovascular, you often get tachycardic because your body's trying to pump extra blood around because it's so dehydrated. Hypotension is a result of the dehydration, which causes ECG changes too, because basically you're losing all your electrolytes as you're trying to flush out all this extra glucose. Metabolic, so you've got polyuria, so going to the toilet a lot. They say you can lose about 7 litres of fluid in a 24-hour period with DKA. Polyphagia, so wanting to eat all the time, which I just have generally, and polydipsia, being very thirsty, because basically your body's gone into starvation mode because it doesn't recognize the energy sources that it has because your cells can't bring in that glucose. With your skin, it's likely to be dry and flushed with poor skin turgor and dry mucous membranes as well. Also with your GIT, you've got abdominal pain a lot of the time. And also I mentioned her weight loss earlier, which is a strong sign of it. So we'll just talk about the pharmacological therapies. So we're looking at 3 main areas. We're looking at fluid management, because they're very dehydrated. Electrolyte management, because a lot of the electrolytes have gone in that dehydration. And glucose management, because it's way too high and they do not have insulin in their body, so we need to fix that and make sure that we're balancing all of those 3 things all at the same time. So I won't go into it too much, but basically the urinalysis and the blood tests that we get from the very start and continually monitoring them gives us an indication of if our therapies are too much, too little, or just right. So first we'll start off with the fluid management. Hydration, it's usually normal saline to help boost the volume and fill up that space where you've let everything go, because often you've got nausea and vomiting as well, which doesn't help in your fluid situation. Monitoring your insulin levels through that time, basically you decide whether you're going to use like a dextrose solution as well. IV fluids, it's mainly during the first 2 hours of treatment, and it's a lot. So just the correction of fluid can actually resolve the acidosis. So you still have to keep checking all the way through as you're doing things. And now we'll look at electrolyte management. With electrolyte management, we're mainly looking at potassium, because of the changes that it does to the heart. Calcium also for myocontractility, magnesium and phosphate. With bicarb, generally they don't do anything about it because it will correct itself, and it's been proven that administration of bicarb to correct the pH can have adverse effects worse than the actual DKA. So the severity of the DKA, other than just based on the symptoms themselves when you first check them out, you're looking at the venous blood gases, and you can see with venous pH and bicarb where they are, whether they're mild, moderate or severe. So with the insulin or the glucose management requiring insulin, first giving a bolus dose will help bring it down a little bit, but then what we need to do is give them a long-term dose, which will be administered throughout the period just to make sure that we can get it on an even level. So the optimal that we want to keep the blood glucose to is between 5 and 10 millimoles. Of course, while you're giving all this fluid, you need to look out for risk factors. So cerebral edema being the first one, which we've talked about a lot. Hypoglycemia, because it's going too much back the other way. hypo or hyperkalemia, because we're giving it because it's run away, but we don't want to give too much. Everybody absorbs things differently. And aspiration because of the nausea and vomiting. But hopefully they've had some metoclopramide or ondansetron or something like that that's been charted, which has minimised that to stop them losing even more fluids. Obviously the diarrhea from antibiotics will make them lose a little bit of fluids, but educate them, and it shouldn't happen that quickly. With cerebral edema, the risk factors, first presentation of diabetes, long history or poor control, and some of the signs early on are headache because of the pressure, irritability because of the pressure, tiredness and vomiting, which are also the same signs as DKA. So most people get a little bit of brain swelling in DKA, that's the way it is. But if you've still got a decreased or decreasing state of consciousness, incontinence or thermal instability, so they're getting hot and cold, check it, just hold it and let the doctors know straight away. And late signs are bradycardia, increased blood pressure, and respiratory impairment because you're just overloaded with fluid everywhere. So nursing head up will reduce that as well. Keeping them upright in bed will also reduce the risk of aspiration too. And of course, figure out what caused it. So in this case, it was most likely the UTI exacerbated it. But again, education and making sure that the management is clear and that they actually have a diabetes plan.